Hey, everybody, Saul Marquez with the Outcomes Rocket. I want to welcome you back again to our podcast. Today, I have the privilege of hosting the amazing Dr. Malaz Boustani. I've had him on the podcast before, and I'm excited to welcome him back. For those of you that haven't had a chance to listen to his episode, let me tell you a little bit about him. He's a geriatrician, a neuroscientist, and an agile scientist with extensive experience in designing, evaluating, implementing, and disseminating healthcare innovations with a main focus on brain health. He used insights from agile science to develop the Indiana University Graduate Certificate in Innovation and Implementation Science and co founded four health tech startup companies. He's just an incredible individual, and he's been doing a lot of research. And as he likes to say, from discovery to delivery. And today we're going to be able to talk about one of the most recent findings and the advancements he's made in particular with brain health. So, Malaz, thanks so much for joining me.
Well, thank you so much for giving me the opportunity again and the platform to exchange information with the public. Thank you so much, Saul.
Of course, Malaz, and folks, I've had the opportunity to attend a couple of Dr. Boustani's innovation camps. I'm always impressed with the level of people that he has in his classroom, both digitally and in person. And so, really, just a pleasure to have him back on the podcast. So really, talk to us about what is top of mind for you, Dr. Boustani.
Oh yeah, I just wanted to share with you the journey and the public, the journey from really discovering a solution to take care of societal problem, and all the way to where this solution becoming very, very close to be the norm, the social norm. And that journey is very rare to be witnessed by one person usually, and I have the luxury to have lived that journey, and I think sharing this journey, the up and down of the journey, the loneliness, the community sense of it. It might give insight to a lot of people who might be on the beginning of the journey and they are thinking about giving up.
Mm-hmm.
And then maybe listening to my story, they get this extra kind of booster shot to say, I can persevere for another month, another year, another 2 years. Because as you all know, crazy people think they can change the world, and everybody know those are the only people who actually change the world for the better. So we need our own support group, and hopefully this will be part of our supporter group conversation.
Certainly, you're always a very inspiring person to talk to, and you've made some advancements, right? You've made some major advancements from a scientific front, the delivery front, and also with CMS. Do you want to cover some of that with us today?
Yeah, let me start with the end. So on July 31st, 2023, just a couple of months ago, the Center for Medicare and Medicaid Innovation announced that they are going to be testing for at least 8 years an alternative payment model to create demand so the healthcare system will be delivering the evidence-based dementia care services that us and other scientists across the country have been working on it for the past almost 20 years. So that's the great,
That's
exciting
incredible.
things.
Congratulations.
Oh, absolutely. So technically, beginning July 2024, so almost a year from now, doesn't matter if you live in Indianapolis or if you live in LA or if you live in Baltimore or if you live in around San Francisco or around Emory. You don't need to be living in these kind of spot to receive this evidence-based dementia care model, because the CMS gonna try to spread it out and make sure it's available to a lot of people across the country in the United States. So that's the great news. What I want to share with you, how was the journey happened and what it takes. So I want to go back from July 31st, 2023. I want to go back all the way to early 2000. So in early 2000, 2002, I came into Indiana University from University of North Carolina, um, and finished my geriatric research fellowship. I became a faculty. And when I came into Indiana University, my mentor, Chris Callahan, who was an amazing person, who recruited me there because I wanted to be like him, modeling, he already was able to get funding to conduct a clinical trial, randomized controlled clinical trial, to test a model of care, to see if we could reduce the burden of dementia, not just on the person who is suffering from dementia, but on their family caregiver. All right. So he designed really good model. Ironically, his model that he designed, I was I came up with the same concept just a couple of years before him, but he was ahead of it. He actually tested it, and he took a sabbatical in England to really design that model and wrote a grant and got the grant funded from the Agency for Healthcare Research Quality. So I came over to execute that clinical trial. And it was very exciting. We called it the Cadillac model. What we did, we just simply said, the current healthcare services for people with dementia in primary care is completely not good. We want to redesign it. All right. So we didn't come over and point finger at the primary care doctors or anybody else. We actually brought in resources to the primary care system in a package in the right way to see if that worked. And we want to evaluate it in a very, very, a high caliber, the same way you evaluate a drug, to do a randomized control a trial. And our model was very simple. We did not, we just simply did two things. Number one, we expanded the definition of patients from the patient who suffered from the disease to their family member who are caring for them. So all of a sudden we start seeing dyads instead of one person. And what we did, we brought in resources, a care coach or a care coordinator who helped the patient and family to manage their ability to cope with the cognitive, functional, and psychological disability of their loved one and their own stress level. So that's in a nutshell. We gave them like feedback, processes and tips and evidence-based way to do that. And we tested it. We had 180 people. Half of them got our model, half of them did not get the model. We followed them for 18 months, and guess what? It worked. So we were able to reduce the agitation that patient with dementia have, other behavioral symptom, and we prevented the stress and the burnout of the caregiver. All right. So that was amazing results. It was the first actual randomized control trial that I ran. And I thought everything will be the same after that. I can just move on to other things. So this one worked, and we were able to publish it in a big journal, JAMA. I got promoted to associate professor. I got invited to talk with other people all over Seoul. And then I was supposed to move on, and I actually move on to another problem that I want to fix, which is delirium. And then luck, anything happened, luck hit the ground. and there's been a lot of series. So I can zoom into these luck events, but I want to tell you a big luck happened around 2007 or so.
Okay.
And then another big luck happened around 2009. And mindset things happen. And then really around another 2 or 3 big events occurred that were the really the energy that moved us from a JAMA article in 2006 to a policy change in 2023. So there's a lot of luck in that concept, and you just simply has to be ready to harvest that luck in order for you to actual make an impact, instead of doing what the typical academician like me used to do, which is we discover discover solution, and our endpoint is benchmark, put it on a bookshelf.
Hmm.
That's how we get judged. But I can zoom in into more and more into these little bit of an insight that might be helpful for other disruptive innovator who are trying to really make our society better.
It points to your commitment, not just to publish. Obviously, that's a priority as an academician, but also beyond that, taking the beyond the bookshelf into now what is a policy that can affect all of our lives. Everybody that's listening that's based in the US that could be a recipient of, or families which could be recipients of dementia care, thanks to the work that you've done. And even beyond that, I would say, there's adjacent tracks that can oftentimes take a long time. Like I think medtech, medical device entrepreneurs, oftentimes go through a very long process from a minimally viable product to approved by the FDA. And so I think we could all draw from inspiration and lessons from what you've done. So Malaz, talk to us about what's changing and what the policy is. Would love to better understand that.
Yeah, so the policy, it's starting from July, is big things. So we currently, the fee for service is the dominant a payment a process to take care of medical services and health
Hmm.
services for our country. That concept of fee for service, it doesn't work for people living with dementia. You know, and especially it doesn't work for their caregiver. So what will happen? The model of care that I explained to you, we tried to disseminate it and within the fee for service, and it just didn't work. We were able to have that model or that services in Indianapolis in a safety net healthcare system, that we were able to make sure this model, these services are available since 2008,
Mm.
January 2008. So although we published it in JAMA in 2006, within less than 2 years, we made sure it's available at least in Indianapolis, in a safety net healthcare system that serve 50% African American, almost 50, 60% dual eligible, so socially frail, underrepresented population. So we succeeded in implementation quickly there, but we never were able to kind of expand our services because our model was not compatible with fee for service. We raised funding. We did like foundation campaign. Askenazi's leadership and their commitment to the county, kind of kept us on a life support. Does not have enough capacity to expand.
Hmm.
So we noticed right away that was a big problem. So this alternative payment model that will be tested by CMS is actually used different way to cover the expense of these health services. So what they do, they're doing two things that are really amazing and were highlighted by a group of us, a village of across the country, a group who really work with CMS to adopt this model. Number one, they're gonna do what we call PMPM model. So they're gonna pay the healthcare delivery, the organization that will deliver this model. They're gonna pay them a flat fee somewhere between, let's just to make it easy, somewhere between $200 to $300 per member per month on top of the fee for service you do it. So that's give a lot of flexibility, that give a lot of scalability, sustainability piece. So that's, if you think about it, that's somewhere around $2,500 per member per year, something
Hmm.
like that. All
Hmm.
right. That Then on top of it, what is amazing about CMS goal is they're going to give another up to $2,500 um, for the patients to use for respite care.
Mm.
for the caregiver to use for respite care.
Yeah,
So in a nutshell, if you take both of them, is like $5,000 a month and almost $60,000 on average, $60,000 per member per year. All right. People say, wow, that's a lot of money compared to the new disease modifying agents that might be available. CMS is going to pay double that if you look at the wraparound services. So in a way, this is save money. So that's what they're going to be testing. They're going to be testing, is this model, payment model, will facilitate the services, the dementia care services, and it does it actually even on the long run create better care, better health at lower cost. Because our model, even though improved the behavioral and psychological symptom of dementia, caregiver stress, kept people at the community at home longer, on average of 2 years.
Wow.
And if you take that money and translate it over 10 years, we did some, not us, the group of us, the Alzheimer Association, AARP, Us Against Alzheimer Disease, the Milken Institute, investigator and scientists from UCSF, from UCLA, from Emory, from Hopkins, from Wisconsin, a group from Brown. This is the village that were behind the scene that converted took this thing from the bookshelf and made it reality. We projected over 10 years that can save billions of dollars to the federal government. So this is a smart financial decision on CMS. This is one of the rare situation where everybody will win. Obviously the patients and their family member, the healthcare providers who are passionate to support them, including community-based organization, and the federal government. That is for me what I think of it as a smart healthcare policy. And it's been 20 years. It took 20 years of amazing work. It took 20 years to go against my wrong intuition. As a human being, like all of us, I'm very selfish. I want myself, but you can't, for this kind of thing, you can't you can't do it on your own, number one. And you have to make sure you can you can recruit and maybe work and let other people lead. So the beauty of all this stuff is my contribution to this whole journey was more of a catalyst a little bit. The last 5 years, this entire work was done with amazing people who put, for every 1 hour I put, they might have put 100 hours on top of it. And they are the one who finished the race,
Yes.
Like it was more of like a relay. And they were really the hero. And all of us together, we became a village that led to this amazing story that will help a lot of vulnerable people who suffer from dementia. And ironic, we as a family, my family, got touched by dementia on both sides. My in-law, to my in-law, my mother and father-in-law lived with dementia for quite some time and suffered. We as a family suffered. And ironically, I wasn't able to help them as I like to, because the model of care that we have was not available where they are. And then my father, who is still alive and who's currently live with dementia, he is in Syria. So my journey for the United States is just the beginning. I have to make sure this model is scalable and can be delivered to an underserved, like a people in Syria where civil war is still going on and everything else. So the journey is not over globally, but at least in the United States, we are very excited about what's going to happen over the next 8 years.
I have a ton of questions left. Maybe we end up doing a part 2 to this, because it's one thing to know about it. It's another thing, how do we take action on it as providers, as caregivers, as payers, right? How do we take action on this new policy that's available for us to better take care of ourselves, our loved ones that may be faced with dementia? So Malaz, if you're up for it, let's do a part 2 for today.
Sounds perfect.
Today was about the what, and our next one will be about the how. But folks, we'll leave links to today's podcast in the show notes. from Dr. Malaz Boustani and the work that he and his group of what did you call them? A
Village.
village, yeah, his village of very dedicated contributors to this project, for you to understand it more, what it means, and then we'll touch base for a part two on this to figure out what you can do and how you can get engaged to take advantage of this hard work that's taken 2 decades to now be available to all of us. So, Malaj, just want to congratulate you and thank you for jumping on the podcast to tell us about it.
Oh, thank you so much, Saul, and keep up and working on awareness and spread information that are factual, which is awesome.
Thank you, Malaz.